Hello, my name is Shannon Allen, and I'm a doctoral student at North Central University studying the psychology of violence. Today I'm going to discuss violence in the workplace. Today's presentation will include definitions and types of workplace violence, statistics on workplace violence, analysis and prevention that includes the following components: management commitment and employee participation, worksite analysis and hazard identification, hazard prevention and control, safety and health training, and record keeping and program analysis. So what precisely is workplace violence? Workplace violence is described as violence, threats, harassment, intimidation, inappropriate or disruptive behavior that causes an individual to fear for their personal safety while at work. The Occupational and Safety Health Administration, or OSHA, separates workplace violence into three categories. Type 1 violence occurs where the perpetrator has no relationship with the business or its employees. An example of this would be a robbery. Type 2 violence is violence directed at employees that generally occurs during normal duties. This will be the primary focus of the presentation. However, I'll also touch on Type 3 violence, which is employee-on-employee violence. Violence in the healthcare setting is especially complex because healthcare is, in general, culturally unique. For example, you might believe that dealing with violent patients is just part of your job because you feel an ethical duty to protect and do no harm to the patients. And therefore, the risk of patient violence may be considered routine and expected. So I'm sure some of you have probably put your own safety at risk because you may feel that patient violence is a refractory unit of their illness. These factors often result in organizations failing to implement prevention and employee safety programs. Now let's go over some statistics. Let's first discuss statistics on general workplace violence. About 20% of violent crimes happen in the workplace. Approximately 2 million U.S. residents are victims of workplace violence each year. Over 1,900 homicides occur in the workplace annually. The most common types of workplace violence are simple assaults. Simple assault is an attempt to cause one serious harm, such as throwing a punch and missing, or causing an individual to be in fear or imminent harm, such as a verbal threat or nonverbal threat like waving a fist. It's estimated that 1.4 million workplace simple assaults occur each year. More serious assaults account for nearly 21,000 injuries and 450 deaths yearly. And about 51,000 rapes and sexual assaults occur in the workplace each year. In general healthcare settings, 75% of workplace assaults occur in healthcare sector. The most common types of workplace violence is kicking, shoving, hitting, and beating. The incident rate for non-fatal assaults in ambulatory care is 3.1 per 10,000 employees. For hospitals, it's 12.8 per 10,000 employees. In nursing homes and other residential care facilities, it is 21.1 per 10,000 employees. And in 80% of healthcare workplace violence cases, the patient is the offender. So, as you can see, the healthcare sector is the most vulnerable for workplace violence. In mental health care settings, non-fatal assault rates for mental health workers is 124.9 per 10,000 employees. In comparison, the rate for all professions is 2.1 per 10,000 employees. 80% of mental health care workers have been physically assaulted. 78.6 have been verbally assaulted. 77.2 have been threatened. And 37.2 have been sexually assaulted. and it's estimated that slightly over half of all patients have perpetrated some type of violence against their mental health caregivers. So, compared to all non-fatal workplace assaults, it appears that the mental health sector is at the greatest risk for workplace violence. According to OSHA, Section 5A, the General Duty Clause, employees must provide a working environment safe from hazards that are likely to cause serious injury or death. So, what OSHA has provided is some building blocks that may help healthcare administrators develop a workplace violence prevention program. The building blocks are management commitment and employee participation, worksite analysis and hazard identification, hazard prevention and control, safety and health training, and record keeping and program analysis. Typically, before developing a prevention program, you will need to assign a task force. Ideally, the leader should be somewhat knowledgeable about workplace violence prevention and should have the authority to secure the necessary resources to implement the program and the authority to make changes to organizational policies. Task force members should be recruited from all affected areas. This includes managers, supervisors, crisis intervention team members, inpatient and outpatient staff, counselors, patient advocates, stakeholders, and union members, to name a few. A strong task force is the key to a successful program. Once the task force is organized, you'll need to collect baseline data in order to identify issues. This can be done with focus groups, surveys, and interviews. So let's look at an example from the largest healthcare system. The Veterans Health Administration has over 1,700 locations, and they serve nearly 9 million veterans each year. In 2000, they formed a national task force on violence. Their team was very diverse and included representatives from the geriatric, rehabilitation, specialty care, and mental health departments, as well as the police, hospital security, labor representatives, and outside experts. They conducted a nationwide survey and received responses from over 70,000 employees that addressed perceptions of safety if they had experienced violence, employee-on-employee violence, and job satisfaction. The survey allowed them to identify policy weaknesses and triggers and develop solutions. Okay, let's get into the first building block, which is management commitment and employee participation. A strong commitment by management is essential to the efficacy of a prevention program. Management, which may include supervisors and administrators, need to set a tone that violence is unacceptable, and they must follow through with consequences. At the same time, they must build a culture of trust where mistakes are viewed as learning opportunities. One way management can set this tone is to educate employees, patients, and visitors about the violence prevention policy. Other ways are to hold regular meetings, encourage employee involvement in the decision-making process, and address safety concerns in a timely manner. A culture that does not tolerate violence makes workers more likely to report incidents of violence and have faith that it will be addressed without fear of reprisal. Let's go to an example of management commitment and employee participation. St. Agnes Hospital in Baltimore, Maryland uses an electronic incident reporting system. Once a report is made, those involved discuss the incident and how it could have been prevented in a blame-free environment. For the most violent offenders, the task force bans them from the premises. St. Agnes also encourages the use of employee assistance programs for those that have experienced violence. If an employee wishes to press charges against a patient, the hospital provides practical and financial support. And lastly, each department has a subcommittee that meets regularly. One person from the subcommittee is part of the safety task force. The next building block is worksite analysis and hazard identification, and this is an ongoing process. Typically, an analysis includes a risk assessment, review of records and procedures, employee input, patient input, and walkthrough assessments. While risk for your particular organization may vary, here are some workplace violence risk factors common to the healthcare sector. Working with patients who have a history of violence, who have substance use issues, and who may have distressed friends and family waiting. Working alone, especially for those who work in patients' homes. Poor environmental design that interferes with escape or inhibits your vision. Poorly lit parking lots, corridors, and rooms. Transporting, moving, and lifting patients. Lack of an emergency communication system. The possession of weapons by patients, their families, and friends. Working in neighborhoods with high rates of crime. And other risk factors related to organizational practices include prioritizing patient satisfaction over employee safety, understaffing, especially during the night shifts and meal times, high turnover rates, unrestricted public entrances, long waiting times for services in uncomfortable and overcrowded waiting areas, inadequate security, lack of hospital violence prevention and intervention strategies, and a culture that nurtures the perception that violence is tolerated. Also part of the worksite analysis and hazard identification block is a review of records and procedures. Records and procedures review involves a review of certain records that can identify trends. Records typically used include injury logs, as required by OSHA, hospital injury or near-miss logs, police reports, daily logs, and other types of logs and incident reports. Other records that should be reviewed are violence-related workers' compensation reports, insurance records, and threat assessments. Employee input, as previously discussed, can include periodic anonymous surveys. Surveys are helpful before a prevention policy is implemented, as well as after the policy is implemented, and also when policy changes take place, as they can help monitor the program's efficacy. Patient input can also be obtained with formal surveys and focus groups, as these are useful in capturing issues from a patient's perspective. For example, you may want to ask what type of security measures would help them feel safe and the most comfortable, and they can also help you identify triggers to violence. The last action in the worksite analysis and hazard identification block are walkthrough assessments. Walkthrough assessments should cover the entire facility, including outside, and should be done regularly to identify safety and security issues, as well as making sure that solutions are being properly implemented. An example of worksite analysis and hazard identification comes from St. Cloud Hospital in Minnesota. St. Cloud Hospital is a 489-bed facility. In 2010, after a sudden uptick in violent events, the hospital director implemented a technique called the Failure Modes and Effects Analysis. Generally, the FMEA process first identifies potential issues, then their causes and effects, and lastly, prioritizes recommended improvements by severity, probability of occurrence, and ease of detection. FMEA varies in form depending on the company distributing it. But here's an example of one FMEA worksheet from Quality One International. I won't go into great detail about the FMEA model, but if you'd like more information, the Veterans Administration National Center for Patient Safety offers a training presentation at this website. And here are some other risk assessment resources. Now, on to the third block is hazard prevention and control. Once you've identified your hazards, it's now time to address how to prevent and control them. Typically, prevention and control standards fall into two categories: engineering controls and administrative and work practice controls. It is best when both controls are implemented simultaneously, and it is important to balance controls with providing a welcoming, comfortable, and calming environment. Engineering controls are physical changes that either eliminate the problem or create an obstacle between employees and the problem. This may involve installing visibility mirrors, improving lighting, installing technologies like surveillance cameras, panic buttons, and metal detectors, access control of certain areas, changing floor plans to improve line of sight for employees and make exits more accessible, and closing employee stations, and replacing furniture with alternatives that are either heavier or fixed so they can't be used as weapons. Administrative and work practice controls involve changes to the ways that the staff perform tasks. This may include procedures for assessing and reassessing a patient's potential for violence. Risk factors may involve their physical, social, psychological, and financial well-being, and histories of violence, arrests, financial instability, anger, trauma, and alcohol or drug use. Procedures on how to handle high-risk patients, training on trauma-informed care and de-escalation, protocols for communicating and tracking patient behavior so information can be easily assessed from shift to shift and department to department. Adequate staffing, paying special attention to times when departments are typically understaffed, such as meal breaks and nights. Emergency protocols for when an incident occurs, and strategies that minimize distress for patients and their visitors, such as a comfortable, uncrowded waiting room and reduced wait times. So let's look at an example of engineering controls and how these two hospitals took steps to make waiting patients and families more comfortable by constructing comfort rooms. These rooms are comprised of soothing colors, comfortable furniture, soft lighting, and other stress-reducing sensory aids such as quiet and comforting music and activities such as puzzles and games. And here are some hazard and prevention control resources. Moving on to the fourth block, safety and health training. The purpose of training is to increase your confidence in managing and de-escalating violent behaviors. Training should be tailored to meet the needs of your risk assessment, but some general objectives may include an overview of violence prevention policies, securing patient risk profiles, methods for assessing and documenting patient behaviors, location and the use of safety devices like panic buttons, risk factors, de-escalation techniques, self-defense techniques, when it's appropriate to use physical restraints or medications to control aggressive behavior, dealing with aggressive individuals aside from patients, the use of employee safe rooms, general action plans for incidents like codes, which include communication and alarm system protocols and how to get assistance, how to address individuals not directly involved in the incident, such as friends, families, and other witnesses, how to protect your coworkers, and this includes working in teams when possible, policies on reporting, policies on record keeping, procedures on obtaining legal assistance, workers' compensation, counseling, and medical care, how to recognize situations that might escalate into violence, and preventing conflict among staff. Before moving on to the next stages of safety and health training, I'd like to go into a little more detail about the last two items, as these seem especially relevant to the issues you're having here. So let's first examine how to recognize escalating behavior that may lead to violence. Typically, assault is preceded by 3 stages. These stages are warning signs that a patient may become violent. First, there is the manifestation of anxiety. Being a mental health facility, I'm sure you can recognize the signs, but generally the patient may show signs of discomfort or tension, such as rapid breathing, fidgeting, tapping a pen, bouncing their legs, or drumming their fingers, and so on. Next, they may become verbally disrespectful and begin challenging you. And last, they may begin posturing in an intimidating manner or begin making threats. Now let's examine how to prevent conflict among staff. One of the key ways to prevent staff conflict is to develop a set of bylaws that include a disciplinary structure. When employees know the pathways to discipline and the limits of inappropriate behavior, they tend to resolve conflicts on their own. Also, understanding why conflicts rise is important to prevention. From an employee's perspective, the following may trigger bad behaviors: lack of communication, employees not doing their fair share of work, unnecessary criticism, rules for the sake of rules, preferential treatment, inequality, unreasonable expectations, lack of priorities, personal work interference, clock watching, and embarrassing, ignoring, or berating one another, especially in front of patients, staff, administrators, and visitors. Administrators should take care in not taking their employees for granted, keeping promises, taking responsibility for their own mistakes, and practicing what they preach. This helps build a culture of trust where employees feel confident that appropriate disciplinary measures will be taken without reprise. Okay, so let's get back to safety and health training. So how and how often should training occur? Classroom instruction is appropriate for policy and procedure overviews. Hands-on instruction is more effective for learned skills like self-defense and de-escalation techniques. Just-in-time training is helpful when a supervisor sees a staff member struggling with an aggressive patient. Ad hoc training is particularly useful following an incident. These training sessions do not necessarily need to include the entire organization, but rather can just include the department where the incident occurred. While web-based instruction cannot provide hands-on training, it's useful for policy updates to the existing program, and it's also time flexible, which makes it ideal for shift workers. The Center for Disease Control and Prevention offers an online training course at this website. In terms of frequency, first, it's important that all new staff receive full training as part of their orientation. Many healthcare organizations have found that monthly or quarterly refreshers reduce violent incidents. Full training and refreshers should be made available to all shifts, and everyone should attend. And to prevent understaffing, employees who cover for those in training should be adequately compensated. Now let's look at an example of a training format offered by the Shepherd-Pratt Health System. The Shepherd-Pratt Health System provides training in real time by employing safety coaches and mentors to step in when a staff member is having trouble de-escalating a patient. Real-time training has several benefits that have resulted in the Shepherd-Pratt Health System experiencing a decrease in violence. Real-time training offers the opportunity for employees to apply skills in their actual work environment through realistic demonstrations. And here are some safety and health training resources. The last block is record keeping and evaluation, and these are essential to analyzing your program's efficacy. These tasks can help you recognize hazards that were initially overlooked and can assist in keeping your program updated to reflect current trends. Record keeping also provides you a way to communicate trends to employees and other stakeholders and opens an organization-wide dialogue on ways to improve your program. Accurate tracking is largely dependent on the ease by which employees can report incidents, if the responses are timely, and if they yield positive results. The best reporting methods are electronic and should be tailored to your organizational needs in terms of the range of incidents that can be reported. In addition, the employees' and patients' confidentiality must be protected, so when you're presenting report data, you should remove all personal identifiers. Accurate records should be kept on patient histories, training, hazards, assaults, and corrective actions. These will help administrators determine the scope and severity of workplace violence, identify trends and locations where violence occurs, and evaluate the efficacy of the program and identify training gaps. So not only is record keeping important to maintaining an effective prevention program, some reporting and records are required by OSHA. When an employee is injured at work, you must report incidences that result in death, days off from work, transfers, restricted duties, medical treatment aside from basic first aid, loss of consciousness, and significant injuries. These records must be maintained for at least 5 years, and employees have the right to access these records. The following forms with instructions can be found on the OSHA website. Form 300 is a log of work-related injuries and illnesses. Form 300A is a summary of work-related injuries and illnesses, and Form 301 is an injury and illness incident report. Comprehensive program evaluations generally involve an analysis and review of the following processes: meeting minutes, measuring improvements, employee surveys after changes to policies, regular employee surveys to determine if they have experienced violence, making sure all records are current, tracking recommendations, education of new strategies, compliance with OSHA, relationships with law enforcement, consultant reviews, and records that you should be looking at are OSHA Form 300 and 301, medical reports of injuries, workers' compensation reports, supervisor reports, corrective actions, patient records with a history of violence, crime, and drug abuse, and training attendance. And some tools for reevaluation are analyzing barriers that you've encountered, incident reports since the last assessment, and documentation of changes after assessments. Now let's look at an example on reporting from Ascension Health. They use a computerized reporting system called the Dynamic Online Event Reporting System, or DOERS. DOERS is accessible from any computer connected to the hospital's central system, and reports are automatically forwarded to the appropriate entities, including their immediate supervisor. However, employees can also choose to not send the report to certain individuals if the report involves the individual, such as in the case of bullying incidents. Since implementing the computerized reporting system, they have had an increase in the number of reports received and a decrease in incident severity and injury rates. And here are some record keeping and program analysis resources that you might find helpful. In closing, I'd like to again stress that these recommendations are not specific to your organization, but rather they serve as a blueprint by which to tailor your program to reflect your risks. I'd like to thank you all for coming, and I'll leave you with a few general resources that might help you develop your program.